Hi and welcome to today's presentation on arrhythmias. So in an outline, we shall look at the causes, symptoms, diagnosis, and how to manage arrhythmias. So when we say arrhythmias, it comes from the Greek word a, which stands for loss, and rhythmos, which represents rhythm. And so arrhythmia simply means loss of rhythm. For descriptive purposes, we say arrhythmia is a group of impulse generation or conduction disorders within the myocardium, which leads to irregular heartbeats, bradyarrhythmias, and tachyarrhythmias. Now, during arrhythmias, the heart can beat so fast, which we call tachycardia, or too slow, which is called bradycardia, in the presence of loss of rhythm. And so, if a person has a very slow heart rate of less than 60 beats per minute, together with arrhythmia, we say the person has bradyarrhythmias. And if the person has a fast heart rate of 100 beats per minute, together with loss of rhythm, we say the person has tachyarrhythmias. And so, as you can see, the problem is specifically with the rate and the rhythm of the heart. Now, let's look at some pathophysiology of arrhythmias. Now, when the conducting system is functioning as it should, each heartbeat is generated in a regular pattern, and this is known as sinus rhythm. Now, the parasympathetic nervous system slows down the heart rate by releasing acetylcholine at the sinoatrial node. At the same time, we may have the sympathetic nervous system also increasing the heart rate by releasing catecholamines such as epinephrine or norepinephrine at the sinoatrial node. And so, under normal circumstances, the sinoatrial node is the primary pacemaker and controls the rate of electrical impulse production within the heart. But occasionally, foci other than sinoatrial node takes over the function of impulse production, causing disorganization in the carefully regulated contraction process of the heart, and this will lead to arrhythmias. We shall look at the causes of such arrhythmias, but before that, we need to see an overview of the normal conducting system of the heart. And so when we look at this diagram, we find that here is our SA node, and it spreads the impulse to the AV node through the anterior, posterior, and the medial internodal tract. And the left atrium also receives impulses through the Bachmann's bundle. Now, from the AV node, the impulses pass through the His bundle, then through the right and left bundle branches. It reaches the Purkinje fibers, then to the ventricles. This is the normal conducting system of the heart. And so, when you look at this animation over here, you can see that the sinoatrial node generates the impulse, then spreads it to the AV node. Then there is a delay of about 0.1 seconds at the AV node, and this allows the blood to leave the atrium to the ventricles before the ventricles also contract. And so from the AV node, the impulses spread through the right and left bundle branches to the Purkinje fibers. Then the contraction of the ventricle ensues. So this is how things happen normally in the heart. Now let's quickly go over the causes of arrhythmias. Now there are two main causes of arrhythmias. We have the first one to be altered production, and we also have altered conduction. Now, if you look at this animation over here and you compare it to the one we just saw, you realize that in this animation, there is no pattern, there is no regularity of the conduction system of the heart, and you can see that the heart is actually quivering, and sometimes you can even see that the atria stops whilst the ventricles only contract. And so this is the situation we find in arrhythmias. And when this happens, what it means is that because the heart is contracting at such a fast rate, little amount of blood leaves the heart, and so cardiac output is reduced, and so the patient may experience fainting. At the same time, you may also find that the coronary arteries receive very little amount of blood, and so this patient also stands the risk of even getting ischemic heart diseases. Now, we shall look at a lot of the symptoms when we get to the signs and symptoms. But before that, let's look at how altered production, cause arrhythmias. And so, the first thing we are going to look at is what we call automaticity. Now, when we say automaticity, it is the ability of the cells of the heart to spontaneously depolarize and generate an action potential. Now, in a healthy heart, only the pacemaker cells possess this natural automaticity. And sometimes we have it in the AV node as well as the bundle of hairs and also the Purkinje fibers. Now, since the autonomic nervous system, as we just saw, has significant control over the SA node's automaticity, an altered sympathetic and parasympathetic activity will affect the heart rate. So we can have an enhanced or reduced automaticity. So in an enhanced automaticity, what happens is that the activities of the sinoatrial node is upregulated, and this can be seen during exercises, in stressful situations, and most importantly, with the use of sympathomimetic drugs such as ephedrine, epinephrine, or norepinephrine, which will result in increased automaticity, which will cause tachycardias. And so, as you can see, enhanced automaticity will lead to tachyarrhythmias. Now, with reduced automaticity, what happens is that the activities of the sinoatrial node is downregulated, either by the activation of the parasympathetic nervous system or through the suppression of the sympathetic system, resulting in bradyarrhythmias. And so, as you can see, whilst enhanced automaticity will cause tachyarrhythmias, reduced automaticity will cause bradyarrhythmias. And the most common cause of reduced automaticity is the use of beta blockers. Another important cause of altered production is what we call triggered activity. Now, this occurs as a result of the instability of the membrane voltage. And so, ionic disturbances, specifically that of calcium and sodium ions, may alter the membrane potential of the heart's myocytes, resulting in abnormal depolarization, which can be either early or delay, occurring after an action potential. And this is what we call after depolarizations. Now, an important thing we should note over here is that triggered activity is usually the cause of long QT syndrome, in which there is a delay in the repolarization of the heart after a heartbeat. Sometimes also we see this in most of the ventricular arrhythmias to be the mechanism. Now, let's quickly look at altered conduction and how it causes arrhythmias. The first way is through conduction blocks. Now, when we talk about conduction blocks, it occurs when the conducting waves or the spread of impulses is terminated, as it is blocked by unexpected myocardial tissue. And there are two main ways through which conduction block may occur. We may have it as a fixed block or as a functional block. With a fixed block, what happens is that the wave of conduction is inhibited by a physical barrier such as a scar tissue. And with a functional block, the conducting impulses meet a refractory tissue, and this prevents further wave propagation. And so the impulses is not able to spread through the tissue which is in refractory. This is often caused by drugs that prolong the action potential of the heart cells, such as the use of class 3 anti-arrhythmics such as amiodarone. Now, another important cause of altered conduction is what we call the re-entry. Now, re-entry occurs when the conducting impulse travels around an abnormal re-entry loop. I will describe this with different diagrams for your understanding. But before that, you should know that we may have a slow, fast atrioventricular nodal re-entry tachycardia, which is the most common, accounts for about 80% of the cases. Then we may also have a fast, slow atrioventricular nodal re-entry tachycardia. Now, let's use the diagram over here to describe the re-entry tachycardias. Now, in order for re-entry to happen, there must be two distinct conducting pathways with different conduction velocities. And so we may have a slow pathway with a short refractory period, and we may have a fast pathway with a long refractory period. By refractory period, I mean the resting time at which the pathways cannot be stimulated or excited again by impulses. And so, one thing I also want to draw your attention over here is that in atrioventricular nodal reentry tachycardia, as the name implies, the abnormality involves the AV node, and so there is no accessory pathway. Now, the slow pathway, the impulses travel slowly but recovers very fast due to what we've just seen, that it has a short refractory period. But in the fast pathway, the impulses travel very fast but recovers slowly due to the long refractory period. So let's look at the normal thing first. Under normal circumstance, what we find is that when the impulses reach the atrioventricular node over here, so the impulses are coming from the atrium, and as it reaches the AV node over here, it quickly enters into the fast conduction pathway straight to the His bundle and finally to the Purkinje fibers and supplies the ventricles. The fast pathway then enters into refractory period. Meanwhile, the impulses slowly enters the slow pathway and moves along it in a very slow manner. And by the time it reaches the fast pathway over here, it will still be in refractory, and so it cannot stimulate or excite the fast pathway again. And this leads to the termination of the slow pathway, as we can find over here. The slow pathway enters into refractory period. After this, as the fast pathway also enters into refractory period. And so both pathways recover from refraction and once again can be stimulated by receiving impulses. And this is what happens normally. Now, assuming a premature beat, such as a premature atrial contraction, enters the AV node when the fast pathway is still in refractory, but the slow pathway has recovered, what happens is that the impulse will travel slowly. Let's use this diagram. So the impulse is going to travel slowly down the slow pathway, and by the time it reaches the common pathway, the fast pathway may have recovered, and so the impulses can stimulate or excite it again over here, because the fast pathway took some time to recover. And so even though the slow pathway also took a long time to reach the common pathway, it got here when the fast pathway had recovered from refraction. And so this impulse will spread once again to the fast pathway, thereby activating it. Now, when this happens, the impulse from the slow pathway begins to move around, and as it reaches here, by the time the impulse reaches the entrance again, we find that the slow pathway may have also recovered, and so the impulse can excite it again. And so we are going to have a situation whereby impulses will go round and round and round, activating the bundle of His antrogradely, whilst it activates the atria retrogradely. And it does this at a much faster rate than normal, sending impulses to the ventricles, producing a heart rate of about 100 to 250 beats per minute, as we find in supraventricular tachycardias such as atrial fibrillation and atrial flutter. And so on an ECG, even before the ECG, this is what happens as the uh, abnormality occurs. And so we are having a re-entry of the impulse generation, going round and round and round itself, whilst it releases some of it through the His bundle to the ventricles. Now, when we look at the ECG finding, what we find is that on an ECG, we are going to see a narrow QRS complex, which is less than 0.12 seconds, and a fast heart rate of more than 100 beats per minute, which is tachycardia. And so when we calculate the heart rate over here, we count how many boxes, 1, 2, we divide by 300, and we are getting 150 beats per minute. Now, what are some of the symptoms that the patient will present in arrhythmia? Now, most of the patients with arrhythmia are asymptomatic. However, when symptoms begin to present, most patients complain of palpitations due to the irregular heartbeats. And so palpitation is the most common symptom of arrhythmia. Arrhythmia can also be sensed as a flutter or pressure in the chest, causing lightheadedness, dizziness, all because the cardiac output is reduced, and so blood supply to the brain is also reduced, and so the patient may, be getting these fainting and also dizziness. The person also has reduced exercise tolerance. The person may also feel weak and fatigue, as well as chest discomfort due to the palpitations. The patient may also be experiencing some sweating episodes. Now, if the arrhythmia results in heart failure, the patient may experience dyspnea or syncope. Now, I need to stress that some arrhythmias are so lethal within minutes and can easily lead to death, such as ventricular fibrillations. So these are the symptoms of arrhythmias. Now let's quickly classify arrhythmias. Now, basically, we can classify arrhythmias based on whether it is bradyarrhythmia or tachyarrhythmia. And so if it is bradyarrhythmia, the heart rate is usually less than 60 beats per minute. And if it is tachyarrhythmia, the heart rate is usually more than 100 beats per minute. Now, as you can see, with bradyarrhythmias, it may originate from the sinoatrial node or from the atrioventricular node. Now, examples of sinoatrial node arrhythmias or bradyarrhythmias include the sinoatrial pulse or arrest, sinus bradycardia, tachycardia bradycardia syndrome, as well as respiratory sinus arrhythmias. Now, if the bradyarrhythmia is originating from the AV node, we shall have the various heart blocks. And so you may have the first degree heart block, the second degree heart block, and the third degree or the complete heart block. Now, when we pick the tachyarrhythmias, it may be either supraventricular or ventricular. When we say supraventricular, what it means is that the arrhythmias are originating in the SA node or the atrial myocardium or even the AV node. And so usually what we find is that we may find a regular but narrow QRS complex less than 0.12 seconds and a fast heart rate of more than 100 beats per minute. And so examples of supraventricular tachyarrhythmias include the sinus tachycardia, atrial fibrillation, atrial flatus, atrioventricular nodal reentry tachycardia. We may also have multifocal atrial tachycardia, as well as the Wolff-Parkinson-White syndrome. And when we pick the ventricular tachyarrhythmias, what it means is that the arrhythmias originate below the AV node, and so we may have a wide QRS complex. And examples include the ventricular tachycardias. We may also have ventricular fibrillations, premature ventricular beats, as well as torsades de pointes. So basically, this is how we classify all arrhythmias. Now, how do we diagnose arrhythmias? Basically, we may diagnose arrhythmias using a 12-lead echocardiography. And this is a non-invasive test but requires experience to interpret the results. It basically tells us about the heart rate, either there is bradycardia or tachycardia, and also gives us some information about blocks. We can also diagnose arrhythmias using what we call the Holter ECG. And the Holter ECG is a portable 12-lead ECG, which we use to detect infrequent or occasional arrhythmias. And so it is carried by the patient for about 24 hours or even several days, and it constantly monitors the electrical activity of the heart. And so as you can see, this gentleman is having his Holter ECG monitor tagged into his trouser, and the electrodes are placed on the chest, and it records the ECG as he continues with his daily activities. We may also diagnose it using the stress ECG. Now, some arrhythmias only occur when the patient is under stress. And so a treadmill or even a stationary bicycle, or even sometimes we may use pharmacological agents, to provoke these arrhythmias, which is then recorded on an ECG. And so in this diagram, as you can see, this man is walking on a treadmill, and his ECG is being recorded to see if we are going to have any arrhythmias. Then we can also do electrophysiology, and in electrophysiology, sometimes we use it in conditions such as Wolff-Parkinson-White syndrome, and this procedure usually require a study which is somehow invasive and involves sedation and catheterization of the heart, usually through the femoral artery, to detect or to monitor the electrical activities of the heart. Then we can also use the echocardiography. Echocardiography is very, very important when we are diagnosing arrhythmias, because it helps us to identify the underlying etiology of the arrhythmia. And so echo can show us some structural abnormalities such as left ventricular dilatation, which may increase the risk of ventricular arrhythmias such as ventricular tachycardia. Echo may also show us dilated left atrium, which has an increased risk of atrial fibrillation, and we may even see valvular heart diseases on echo, such as mitral stenosis, which is commonly associated with supraventricular arrhythmias. Now, we may have other investigations that we need to do alongside to diagnose arrhythmias. And some of them include the CBC. And we do CBC because we need to look for anemias, because anemia may sometimes cause sinus tachycardia. Also, we need to do the urea and electrolytes to look out for hyperkalemia or hypercalcemia, which may provoke arrhythmias in a patient. Then also we need to check the thyroid function test, because hyperthyroidism is an important cause of atrial fibrillation as well as other tachyarrhythmias. So basically, these are how we diagnose arrhythmias. Now, how do we treat arrhythmias? Basically, we use pharmacological agents as well as some electrophysiological agents. And so, with our pharmacological agents, we use what we call the anti-arrhythmics. or the anti-arrhythmias. And basically, we have grouped these anti-arrhythmics into classes. And so we are going to look at it based on the class, their mechanism of action, the effect, and some examples. And so we have it from class 1 to class 4. Now, when we pick class 1 antiarrhythmics, we have class 1A, 1B, and 1C. And all the class 1 antiarrhythmics block sodium channels in one way or the other. And so when we pick the class 1A, what we find is that they moderately block sodium channels. And since depolarization of the cardiac myocyte is dependent on the influx of sodium, a blockade of the sodium channels will lead to prolongation of the action potential duration, which will cause a negative dromotropic effect on the heart. So basically, we are going to have a reduced conduction velocity in the heart. We are examples of the class 1A, we have quinidine, we also have prokinamide, and also we are going to have disopyramide. Then we have the class 1B. The class 1B anti-arrhythmics also block sodium channels, but this time it blocks it weakly, causing a short action potential duration, which leads to prolongation of the relaxation of the ventricles. And once the relaxation of the ventricles or diastole is prolonged, what we see is that the conduction velocity is also reduced, or it is slowed. So over here too, we have a negative dromotropic effect on the heart. An example of class 1B is lidocaine. Then we have class 1C, which strongly blocks sodium channel, basically blocking the sinoatrial node as well as the atrioventricular node. And examples is the flecainide as well as the propranol. Now, one thing I need you to understand over here is that the class 1 medications are very effective in re-entry tachycardias, such as the atrioventricular nodal re-entry tachycardia, as well as very effective in young people who do not have symptoms of heart failure. Now, and so because of this, we give these class 1 agents in atrial fibrillation as well as in atrial flatus, then also in ventricular arrhythmias. Now, the class 1B is also very good in post-myocardial infarction. Then, I think that is it. So let's quickly look at the class 2 antiarrhythmics, and these are basically beta blockers, and so they block the sinoatrial node as well as the AV node. An example include the atenolol and the bisoprolol. Then we have the class 3 antiarrhythmics, which blocks potassium channels, thereby leading to prolonged action potential. Then, and once the action potential is prolonged, we are going to have a negative dromotropic effect on the heart. Examples include the amiodarone and dronidarone. Then the last class of antiarrhythmics is the calcium channel blockers, which blocks the atrioventricular node, and examples include diltiazem and verapamil. Now, we must know that class 3 antiarrhythmics are very good for older patients who have symptoms of heart failure, whilst class 2 and class 4 antiarrhythmics must be used with caution in patients who are having re-entry tachycardias. Now, apart from the antiarrhythmics, we also have what we call the percutaneous interventional electrophysiology. Now, basically what we do over here is we have two main procedures, which is the pacing and the cardioversion. Now, when we say pacing, it is when we introduce a low voltage electrical impulse to stimulate the cardiac myocytes to cause it to depolarize, especially in bradycardias. And so we use pacing usually in bradyarrhythmias. Now, In cardioversion, which is also known as defibrillation, we give a high voltage shock to depolarize the heart and reset its rhythm, especially in life-threatening tachyarrhythmias such as ventricular fibrillation. And as the name implies, the heart is in fibrils, and so we defibrillate the heart in order to reset it. That is why we give cardioversion. Now, going back to the pacing, there are two main types of pacing, and we have the temporal pacing and the permanent pacing. Now, the temporal pacing is used in acute settings to stabilize patients who are hemodynamically unstable, whilst we use the permanent pacing. Uh, we implant it under the clavicle, as well as we introduce the electrodes into the right atrium, and so we may leave the electrodes in either the right atrium or the right ventricle. When we do this, it is referred to as single chamber, or we can leave it in both chambers, which is called the dual chamber. And so that is for the pacing. It can be temporal, it can be permanent. Then when we pick the cardio version, even before the cardio version, one important thing that I need to draw your attention here is that the pacing possesses what we call sense and pace function, and so it detects the cardiac rhythm and only delivers electrical impulses when necessary. And we must know that it has some disadvantages or some complications, which may include displacement of the legs, as well as wound infection, and sometimes even we may have pneumothorax when we do pacing. Then with the cardioversion, we as I've already explained, it resets the heart, and so we use direct current biphasic shock, and it's usually used in tachyarrhythmias. And so basically, we use them for atrial fibrillation, atrial flutter, and ventricular fibrillation. And the cardioversion can also be in two forms. We may have the electrical or the chemical. Electrical cardioversion is also known as direct contact cardioversion, and the chemical cardioversion, also known as internal cardioversion, and it involves the use of intravenous antiarrhythmic drugs such as amiodarone and procainamide, and this may be indicated in patients with atrial fibrillation as well as atrial flutter. So these are the main percutaneous interventional electrophysiology that we have. But we also have what we call the implantable cardioverter defibrillators, or the ICDs, and these ones are similar to pacemakers in that they detect life-threatening tachyarrhythmias and deliver electrical shocks to terminate them. And so it's important to note that in addition to their defibrillation function, the ICDs also have pacing functions. Then they are also used in both primary and secondary prevention of sudden cardiac death from ventricular fibrillation. And so this is how the ICD cardioverters look like. So we have the battery, the capacitors, then the leads with the electrodes, then the electronics over here. And so when you look at this patient, we have it implanted under the clavicle, and so you see the cables passing through to the veins into the right side of the heart. Then it detects abnormality or abnormal impulse generation. Then it also releases impulses to terminate all the abnormal impulses. And so as you can see in this diagram, I think I have it bigger over here. In this diagram, as you can see, the heart starts beating all right, but after some time, you see it quivering. You see that there is arrhythmia from time to time, and anytime there is arrhythmia, you see that the implantable cardioverter defibrillator, ejects some impulses to reset the heart, and it first terminates the abnormal impulses, then it resets the heart for you to have a normal rhythm as well as a normal rate. So this is basically how the implantable cardioverter works. So this is all that I have for you. Thank you very much for your attention. Bye-bye.